Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, welcome aboard once again, and thank you so much for joining us. And if you're brand new and you just happen to stumble on us, like my friend James just said, Dr. Juliff is the medical director of Vein Clinics of Hawaii. It's actually expanded to Oahu a couple of years back, but prior to that, it was it is on the Big Island. It's on the island of Kauai. It's on Maui, and here on Oahu. And so Dr. Juliff treats lots and lots of patients. His staff and the rest of their ancillary guys are terrific, and we do this show to educate and stimulate and get you to take a look at you and others that you love and see, hey, do I have a condition that needs to be looked at by the Vein Clinics of Hawaii? So what we're going to talk about today, we talk about all kinds of things, but today we're going to talk about the actual treatment experience. So let's assume right now that you have some sort of what Doc's going to call venous insufficiency, or you have some veins, or maybe somebody's taken a look at you and said, you know, you really ought to see a specialist, or maybe your own doctor has said to me, you got to see a specialist. What do you expect? Well, first of all, I guess, Dr. Juliff, what you have to do is find out, okay, nice to meet you, Mike. What can we do for you? Step on in here and let's take a look at what you got here.
Yeah.
I mean, in other words, that's ground zero, right? That's when it starts.
That's ground zero.
Okay, so what is that? What do we start to get the ball rolling? How do you do it?
Well, actually, even before that, even before the patient comes in to get the ball rolling, and I wanted to talk about this, you know, the specifically the treatment experience, because last week we talked about expectations, and some expectations are, you know, realistic, some are not, and we kind of have to manage that, and we have to. A big part of that is just the anxiety of being treated. Mm-hmm. And
that's fear.
Yeah.
Fear and anxiety, right? Same thing, really. Yeah.
So I wanted to talk a little bit more about, you know, what people might expect if they decide to come in and see us, and try to relieve a little bit of that anxiety, because, again, we spend a fair amount of time trying to help people know exactly what's going to happen, because we find that they, you know, the amount of anxiety lessens. But what I would call the pre-consultation period, even before they come into the office, sometimes can be a prolonged period of time. And, you know, why is that? Well, I think that there's probably a number of reasons, but one of the big reasons is that patients don't know they have a problem.
Yeah, we've explained this a few times in the past. It's unfortunate in many respects that vein problems are usually a long time in developing. So people adapt and change and handle it until it gets to a point where it becomes either uncomfortable or painful.
Yeah,
you know,
exactly.
So it creeps up forever.
Right. Yeah, it comes on, you know, very, very slowly over a long period of time. And so many of the symptoms are not obvious that they're related to vein function. You know, I mean, people have varicose veins. They know they can see a big vein on their leg, and they say, "Okay, well, I got a vein problem." But there's a lot of people out there with symptoms like, you know, chronic swelling or muscle cramping or something that we call restless leg syndrome, and they have no idea whatsoever that that might be related to their vein function, and that fixing that problem may relieve those symptoms.
You know what? And we've talked about that many times in the past. And part of that, which I've learned, has been the way in which patients are examined and diagnosed. Because I think that what you've said, Doc, and this is rung true so many times on our show, is that there are any number of things that can be potentially a problem based on symptoms. And there are lots and lots of symptoms, some of which we're going to discuss, that are symptoms for a muscular ache, a broken bone, a venous disease, poor blood, cancer, all these kind of things that can be under one umbrella of a symptom.
Right. Yeah. I mean, you look at pain.
Yeah.
Well, pain in your leg could be due to a whole bunch of different things. Yeah, ranging from nothing, a sprained ligament or whatever, to cancer. So that's all part of the process of trying to figure out what's going on. But another group of people know they have a problem. They recognize that they're having symptoms, but they don't know what it is.
Okay, wait a minute. This is a great opportunity. That's why I said today the modern day primary care physician is like a quarterback. He's dealing people off to where he thinks they might go. And the more specialized you go, maybe somebody thought that they had, a bad knee. They had arthritis. No, that swelling isn't because of arthritis. That swelling is because you got vein. So I'm guessing that a lot of people don't know they have the problem with their veins.
Sure. Yeah. They recognize that they have a problem, but they don't know it's due to vein functional problems. And yeah, getting back to what you just mentioned, we see a lot of people who are referred by their primary care physician, and the primary care physician doesn't really know exactly what it is, but he's asking for advice, and we can do a fairly complete evaluation of the patient and determine whether it's somehow vascular related, either veins or arteries or whatever. And that's the way that you have to narrow things down sometimes.
Are you encouraged that, in the day and age that we live in right now, I would imagine for all of you, you included, Dr. Julep, and many, many others, with so many new medicines and so many things, you really have to be like a walking almanac, or you have to be reading 24 hours a day just to stay up with the profession. So if you're just in one specialty, you can do a better job in that specialty. You might not be able to help me for my whooping cough, but you can take care of my veins.
Right.
But the other guy used to handle me for everything, right?
Yeah.
Whooping cough to varicose veins to, bladder infections.
Yeah, exactly. Yeah. I would not be good at that. I mean, I appreciate primary care physicians because they really have to know so much about, many, many things.
I learned from others, and I know you've mentioned this as well. When you're going through your learning like you did to become an MD, that this area that we're talking about, the vascular system, is not talked about as much as some others. And it's maybe now it is, but maybe 30, 40, or 50 years ago in universities, that was at the very end of your study. And by the way, here's the veins and arteries deal.
Yeah, it was something like that.
Yeah.
I mean, we always, I think, for many, many years, obviously, physicians have studied the anatomy of arteries and veins. But yeah, it's really only been the last, let's say 50 years where the medical advancement has occurred such that we can really have an impact on the disease processes that do affect arteries and veins. Absolutely. So people might know they have a problem and they might be referred by their physician. A lot of people I know they have a problem, and then they see some of our advertising, and it gets spelled out a little bit more for them. So if we in our ad we go, we say cramping, heaviness, muscle problems, and they can identify with that.
Sure.
And so a lot of people ultimately end up in our office from that avenue. But and then there's some hesitations that patients will have.
Let's go to that for a minute, because I do know that some of that is based on, once again, when we talk about venous insufficiency, it's hereditary, can be, and a lot of times you learn about it from a relative who went through some pretty tough stuff to deal with this condition many, many years ago. And I'm thinking that is maybe a major factor, particularly with gals that learned from their mom or their grandma, that just said, you know what, I am way too busy to have all of that pain. I'll just live with it. I mean, how bad can it be?
Mm-hmm. Sure. Yeah,
it can be pretty bad.
It can get bad, and then at some point they decide that they need to have it looked into. But as it relates to venous disease, a lot of people they come in and they may have terrible vein problems, but they said, "Well, I didn't know whether I should come in or not. Am I just being vain about it?"
It's all about the way I look.
Yeah.
But are some people actually relieved by saying, you know what? You're really here at a fortuitous time for this condition, because you have long since passed the cosmetic part of this disease.
Right.
We really got to show you what's going on.
Yeah.
Here.
Well, they're happy when they hear that, because they can now kind of define it as a problem, and once we're able to define it as a real problem, then we can do something to treat it and to get rid of the problem. The other thing that we all often hear is, well, it's not really a medical problem. The varicose veins, well, gee, it's not really a medical problem. Well, no, actually it is. And just as we were saying, a lot of times people will hesitate to come in because they don't know that something can be done for it.
Well, everybody knows about blood disease and knows about cancers and knows about all these other things. And I guess maybe when they find out that, hey, in the center of this whole system called your body are veins and arteries, and everything gets transported to every part of your far-flung billions of cells by this system. So if you've got a problem with the venous insufficiency, you could be suffering a lot worse than you are down the road.
Oh, yeah. And the thing with venous insufficiency and vein disease in general is that,
unfortunately,
it just gets worse with time. It's not like we can, exercise it out of our body or take medication or whatever.
Yeah.
And then the other deterrent that we often hear is, my grandmother, I remember her having vein stripping, and I knew I didn't want that, so I kind of didn't, want to come in and see you guys. So that's another hesitation, and that's something that we fight a lot. We just with respect to educating people that, to let them know that the art of vein care has changed so tremendously over the last 25 years that it really is a completely different world now.
Yeah, and I'm really appreciative of that because many of you have learned in previous programs, I hope, that I'm not just the host of the show and the guy that asks the silly questions, but that I'm also a patient. And I think this is important for everybody to know. And for that reason, I'd like to remind you that you can learn a whole bunch more. You can see some of the stuff we're talking about. You can see some of the symptoms. You can see some of the bad situations go on. You can see some of the good ones. And you can certainly find out where you are in the world of taking a look at yourself and getting treated. So you go to veinclinicsofhawaii.com, veinclinicsofhawaii.com. And the good news is we're on Maui, on the Big Island of Kauai, and here on Oahu. And you can get diagnosed and you can get treated. But it all starts at that. And I think that's why one of the reasons we call today's program the treatment experience is I know how hard your staff works because I've heard it already from listeners that, everybody comes in there with a lot of misapprehension and they just need to be, you got to hold their hand. You got to walk them down the road and show them where they are.
A big part of our job is communication, and just relieving anxiety and letting them keep reassuring them that we have things that really will make them feel better, and try to get them through the process with the most amount of ease that we possibly can.
I do know that patients based on if they're, and there's a lot of different ways, my friends, that patients end up in Dr. Juliff's offices. And that can be word of mouth. Most of it is, by the way, I'm imagining somebody that you've treated that just can't wait to share that with another loved one. Some of it are referrals, and some of it are just plain people that stumble upon this program or your TV stuff and say, hey, red flag, I think that's me.
Yeah, and they come to the realization that, what they have is a problem, and again, it's a problem that we can do something about. But the first time the patient comes into the office, we do what we refer to as a consultation, and so we have the patient fill out a lot of paperwork, and some people get tired of the amount of paperwork that we have them go through. Sometimes they often refer to as being back in school. So we've got a bunch of questionnaires and these kind of things that we have them fill out, and then because we need really a complete history of not only their past medical history and what's going on with them right at the moment, but also family history, because all of that really impacts our evaluation and ultimate therapy. So even though, people get tired of writing down every last surgery they've had, it is still important.
I know. And by the way, it's like, I want to tell you something. Someday, and it might be in Dr. Juliff's offices, but someday they're just going to be like everywhere else. You're going to get handed a little device like an iPad or something, and you're going to say, here, take this thing, and boom. And that's where it's going to go. But I do know that the person you want to tell the truth to in this is yourself.
Yeah.
When isn't it sort of funny that and you must have great communication skills for this. When somebody says one thing and you know you're a doctor, wait a minute. I don't care how many times you tell me this is not what you've got. What you've got is this. Mm-hmm. They want to talk themselves into it. You have to agree with me, right?
Yeah, sure. And actually what happens more often is that people, again, they come in and even though they're coming in and they're seeking help, there's a small handful of people that just need to refuse that they have symptoms because I don't know if they feel like it's a sign of weakness or something, but we've got a list of symptoms that are commonly referred or commonly a part of venous insufficiency, and they have to check yes or no. It's surprising the number of people that come in with everything checked as no. No. All you have to do is look at their legs, and it's obvious that they have some kind of vein problem.
Well, that's why I was saying. I mean, that experience. However, it is extremely important. It must be a lot easier in some respects if somebody's come in as a referral from a relative or a good friend, or when somebody comes through. Now, for instance, let's talk about this. There are a lot of things that happen for venous insufficiency in the legs. That's where we're talking most of the time. In the lower part of the leg with skin discoloration and all this stuff. I know that there's some people that say, well, that's my diabetes. Or when some people say, well, that's my allergies. Or somebody says, that's my sunburn. And if you keep putting, some antibiotic treatment on it for 6 months and it doesn't heal, you're wrong. And maybe even another doctor might be wrong about something like that. Yeah. So let's talk about that a little bit when finally people do come in there. And would you please just sit down? It's going to take you a little bit of time, but the more you fill out for the doc, the better it's going to be. And so immediately when you see my questionnaire, before we've met face-to-face, that your staff has done with me, you already know. You can already tell a fair thing. You
have a pretty good picture of what that patient's all about. Yeah, things that you wouldn't think are important are. For instance, my mother had a blood clot when she was 29. Or my father had. He had a bleeding disorder or a clotting disorder or whatever, but all of those things are important because it will have an impact on what we might do to figure out what's going on with that patient.
That's really interesting, and let me ask you this because I'm sure that there are other people out there thinking the same thing. There's so much money, I guess, in pharmaceuticals. That there's so much money being spent on advertising, and I think it's opened up a lot of ideas about different illnesses. For instance, I notice now they say DVT. If you have DVT or HIC or all of a sudden they're talking about the things that we talk about, which means that all of them are saying this medicine may help you do this, but it might also do this. If you get suicidal thoughts, don't take this anymore. This kind of thing. Yeah. But does that sort of open people's minds to say, you know what, I might have that. I don't want to take that stuff because I don't want to get sick. I want to go see somebody.
Sure, I think it does have an impact. Yeah, definitely.
Yeah, and that's. And are you as surprised as how much of that is on television? I mean, every night there's and you can never say the name of the thing. It's all the TBGB.
It has. I mean, that's been a real trend over the past 10, 15 years where pharmaceutical companies are now marketing to the patient directly. It used to be that they just marketed to the physician, but they're going to the source.
Well, there's also, and this is another problem, just as a bit of advice, friends, a lot of times there are online services that you Google this and Google that, and you think you're ordering some kind of medicine and you think you're getting a deal. You better be very careful about that.
Yeah.
Well, that's one thing you're not going to do. You won't get vein stripping done at all anymore, and you certainly won't have venous insufficiency treated online. You have to actually see somebody that knows what they're doing.
For the most part, that would be the better way to do it.
Okay, so I've done my questionnaire, and you've got me in there, and you're doing the initial consult with me.
Mm-hmm. Yeah, the next thing that happens is that someone from our nursing staff will then spend a little more time talking to the patient and go over a few of the questions in a little more detail, especially as they pertain to symptoms and history. We also take pictures. So the first time somebody shows up in the office, we take pictures of their legs so that we have that as a reference. in the future. And then also, a lot of times some of the insurance companies will want to see pictures of the
Interestingly,
patients
that you say
before
that.
they allow us to treat them.
When you first started in practice, it was a lot harder to take pictures of people, wasn't it?
Yeah.
I mean, today you whip out the old cell phone or a device or a nice digital camera, zippity-doo-dah, you got it in the file, you can email it to the insurance company.
Right.
Yeah.
Exactly. That's exactly what we do. So, and then the nurse will also measure the legs of the patient, and we're doing that because of the fact that we are fitting them for compression stockings, which invariably is going to be a part of their, pre-treatment therapy, as well as, using them after we do the procedures.
Are some people, I do know that a lot of people know that when they buy a pair of shoes, one shoe might be a little tighter than the other, that our feet aren't exactly the same. And I would imagine there's sometimes a patient will find out that one leg is a lot bigger than the other, and they don't even know it because they've just gotten used to that. Does that happen?
That happens.
Yeah.
Sure. Yeah. I mean, we try to keep the stockings as comfortable as possible. But just by virtue of the way they're constructed, they're a little, they're tight and they're warm, and people in general don't really, appreciate them as much as they should.
The people that have come in for just that, I mean, they've had venous insufficiency, they've been treated, they got a good result from compression, they just need some new ones.
Yeah. Oh, yeah.
And
definitely.
so you have somebody there that can professionally determine what stock numbers for my foot, for my leg. Yeah.
Absolutely. And we've got a variety of different brand names, too. And each brand name has, various styles. So, the good thing about compression stockings, since they are such a huge part of treating people for, vein disease, and then also just those people with vein disease being able to wear them indefinitely in the future, especially in those, settings where they really need the compression. There's just a host of different styles and colors, and, you could, there's sports socks, and there's, the sleeves, and there are dress socks, and just all sorts of things.
And I'm learning this, my friends, that what happens is it's just an ongoing maintenance thing, and you get over the sticker shock. These are medical garments, not socks. I mean, you can go to a discount store and buy 6 pairs of sweat socks for $8, and you think, wait a minute, what's the deal? Well, it's interesting that you talked about this before. These were developed, I think, in Germany or something. These socks, and they really aren't. I mean, they're socks because they cover your leg and your foot, but they're socks on steroids. I mean, they're really something.
Yeah, the technology behind the development and construction of those stockings, it's quite a bit more than the sweat socks that you
but even the way they look. I mean, when you examine them, which I've done, the material doesn't all go in the same direction all the time.
Right.
It's not just this came off a loom and it's all the same. It changes, doesn't it?
No,
from the toes up to the
it
calf.
Does. It does. Yeah, they call them graduated compression because the greatest amount of compression is down by the foot and ankle, and then it decreases on its way up, and that's kind of how it works.
Okay, so if you have been denying these things, or maybe you got treated back in the day when these things that they're talking about, these compression things, you wouldn't be caught dead outside of them because they look like you had, a couple of army blankets wrapped around your leg.
Yeah.
They were huge, these things before.
Yeah. They were pretty institutional.
Are there some that will use those at home?
Oh, absolutely.
Yeah, I would imagine that
absolutely.
Wearing the nice fashionable socks out when you're working, but when you come home, strapping on that puppy and doing some elevation must be a big help.
Yeah. I mean, we encourage people to utilize, compression stockings even after we've treated them. And by and large, almost everyone finds a time when they are going to, when the way that they make their legs feel, which is better, they find those periods of time when it really is of benefit.
But don't worry about getting walked into the socks boutique at Vein Clinics of Hawaii Day One. I mean, that's going to come along sooner or later.
Yeah.
But it's just part of the overall ability for you to be a one-stop shop, whether it be cosmetic or serious surgery. That's what you do.
Yeah, well, compression stockings are such a huge part of, the therapy, the treatment process, such that we really need to have them in the office so that it's convenient for people.
Yeah, and by the way, a lot of that is not because you want to open a boutique, a clothing section or anything, but you need to be able to, instead of give somebody a slip and send them some good luck, that you must know, but because particularly here in Hawaii, we have different requirements. There's a lot of big people, a lot of big sizes, and all that kind of stuff. So pretty much you need to be able to fit everybody.
Yeah. So after the patient comes in and we do the initial questionnaire and the nurse sees them, takes pictures, and et cetera, then one of our providers will see them, either myself or a couple of the other providers that are in the office. And, like you said before, by then we have most of the historical information all written out on, the questionnaires that we were looking at. So we have a pretty good idea about what that patient's all about. But the most important thing that we do then is the physical examination. We look at their legs.
Now, let's make sure that people know when that happens, you've already done a fair bit of consulting. You've done the questionnaire. And so now, and this is where your staff and you come in, I think that by the time a patient gets to that, they are anxious to find out.
Oh, yeah.
Rather than apprehensive or anxiety, they are anxious because, okay, I've filled out the papers. You talk to me. I know this and I know that. Now what's going on here?
They're looking forward to an explanation. Sure. But the physical examination, we're looking at not only the outward appearance of the legs and the telltale signs of venous insufficiency. Does the patient have swelling? Does the patient have skin changes? All those things. And then also make sure that there are good pulses in the feet. The pulses have are a reflection of the arterial part of the circulation. So we have to make sure that, all of that is intact too. And then we have to decide whether there's some urgency in treating them, or can we just do the evaluation in a little more leisurely fashion? Well,
how many people find out when in normal course of a conversation, maybe particularly if they're retired, they've got a lot of things on their bucket list. They want to go here, they want to go there, they want to go on cruises. Their grandkids couldn't afford to live in Hawaii, so they've moved to Connecticut. They want to go see that, and you might are some of them worried that you might say travel's not a good idea until you get this dress looked at?
Yeah. Fortunately, though, that doesn't happen very often. We can treat, if travel is in their near future, there's usually a way to allow for that to happen, and we can work around those things. The main thing that sort of pushes us to treat people a little more urgency. Well, there's two things, really. People who come in with active ulceration, and that's the highest, level of vein highest classification of venous insufficiency that we've talked about in the past. And so often we need to do something a little more urgently with respect to just how we're going to, are we going to use some sort of dressing or, what type of compression, et cetera, et cetera. So in that situation, it's much more urgent that we do something right away. Yeah,
I'm glad you brought that up because here's another thing, folks, that I want to share with you. This is another thing you can learn at veinclinicsofhawaii.com. There's some great photographs there that show a not so good looking leg and a good looking leg and some ulcers and some of the things that we're talking about. And that's why I'm guessing that if there's an ulcer involved in it, what you're really talking about, before you can get into getting real treatment done on the varicose veins, you really got to manage that thing because isn't it screaming out for attention?
Yeah. Because, we want to do something to, bring about healing as quickly as we possibly can. And you're right. It does interfere with treatment sometimes. Sometimes it interferes with our ability to evaluate the patient.
Yeah, I was going to ask about that. Yeah.
If the patient has a tremendous amount of swelling, especially in the lower leg, that is often the case with people who come in with active ulceration. Sometimes there's so much fluid in the lower part of the leg that we can't do a real adequate and reliable kind of ultrasound to figure out what's going on.
Too much stuff going on in there, right?
Exactly, yeah.
Interestingly enough, and I do know that once that gets handled, that people have such a sense of direction, particularly, and you've told us this before, I'm just amazed at how long people will endure or put up with something and think they're actually taking care of it by slapping that Band-Aid on it every day for 6 months.
Right.
That's not fixing anything, is it?
No. Yeah. No. Usually not. Yeah. Usually not. Usually there has to be something more. But yeah, it's always surprising what people can get used to, and it's unfortunate because sometimes we see people come in with ulcers and they've had them for months and sometimes even years.
And by the way, gang, not to scare you, but there is not a large percentage of us do not get these ulcers. Now, I did. I had one that was just catastrophic to me because I had an injury and a vein right behind the injury that just sort of had a perfect storm. It took a long time. I thought I was on top of it. It took a long time to take care of that.
Yeah.
And so it's funny because I know this happens. I have referred people to you that say, where I've looked at somebody and say, you know what, I had one of those. And I had it for 6 months. Oh, yeah, I've had this for a couple of months. Well, get out of there.
Yeah.
You know, it's just, because you can't fix me all over until that thing gets dealt with.
Yeah, if somebody has an ulcer on their foot or some kind of wound and it doesn't seem to be healing or moving in the direction of normal healing over the course of several weeks, then, there's something amiss.
Okay, now, and maybe draw the line of parallel, too, during the conversation when I'm filling out my forms and everything else. Do I have am I a type 2 diabetic? Am I diabetic? Do I have this? Do I have that? Because isn't it sometimes the location of this sore or this ulcer is a little bit easier for to determine whether it's venous or something else? Mm-hmm. If it's happening on my foot, is it less likely to be a venous ulcer?
Yes.
Okay.
Yeah, actually, that's a very, very good point because there are several different types of disease processes that can lead to ulceration on the feet and the lower leg, and all of them have a very, very distinct appearance.
Yeah.
I mean, you can almost, not almost. Yeah. Most of the time you can kind of just look at them and say, oh, yeah, that's due to vein, or that's due to arterial insufficiency, or that's a diabetic ulcer or whatever.
Do some people react, holy smokes, thank goodness, because I tried this and I tried that. We thought it was this, we thought it was that. Okay, now what are we going to do about it?
Sure. Yeah, they have an answer, and we come up with a plan. So that, and that's the next thing that happens, after the provider sees the patient, does a physical examination and does some more documentation, then we try to summarize, to the patient, what is it that we think you have. Now we don't know for sure because we still have to go through the diagnostic phase, but typically we have a pretty good idea. We talk to them about venous insufficiency, what that's all about, what that means, and in general terms, we can sort of begin to relate some of the therapeutic kind of things that we have available to us and to them that is going to treat them.
I'm really curious about this, and I've been meaning to ask this for many shows, and I know that a lot of people are the same way. That, they want to blame themselves. And maybe a lot of times they say, well, my mom had this, but that's because she's always eating olives. So it must be olives. I mean, aren't we all looking for something that we can grasp a hold of? And this disease leaves a lot of us, not knowing enough about what treatment options there are.
Sure, yeah.
And what are they going to, how long is it going to take to make me feel better?
Yeah, well, treatment options and also just why. Why do I have
Why
this?
me?
Why me? But so, we touch a little bit on the treatment, and then we also try to start to discuss, again, expectations. What do we think that we can do for that patient, with respect to impacting their symptoms, with respect to impacting their future treatment, their what their legs look like visually, et cetera. So we try to summarize that also during that first visit.
One of the things that we've learned in the past, and this is another reason why you got to go to Dr. Juliff's website. They've done a lot of work to make it really user-friendly. It's veinclinicsofhawaii.com. Vein Clinics, that's plural, of Hawaii.com. And just by Googling it, you're going to get the right direction. And I think that, it really doesn't matter how somebody ends up at your door. But the important thing is that the door's open. And I do know that there are still people that are skeptical about anything, about any sort of a treatment, and they're still in denial. Once you've done this process, and particularly with the ultrasound, how long is it before we have the, come to Jesus meeting about what's wrong with me and how can we go about treating me?
Well, that happens, very shortly after, Now, practically, you mentioned ultrasound, and nearly everybody gets an ultrasound. It's kind of, it's kind of our initial step, and for a good number of people, it's often the only thing that we have to do, unless there are other questions that we really don't have answers for, but. We do, again, just about everybody gets a venous ultrasound. Some people get an arterial ultrasound because it's the same sort of study, but it's done in a little different way.
I was going to ask you that because for those, I've learned this, and I just don't assume that we all know that. The arteries and the veins are only different because the arteries are taking blood from the heart and just spraying it throughout the whole body.
Yeah.
And it's on a one-way trip. At the end of that trip, when it got out to the final extremities, these little things called veins actually pick this blood up and take it back to get its service. So what you are specializing in is vascular surgery, but sometimes arterial surgery is necessary too. So does some of that get uncovered in that initial diagnosis of me?
Oh, absolutely.
Yeah, that's really important.
Again, getting back to, any one symptom maybe being caused by a number of different things. That's absolutely true. So, we always have, periodically we have people who are coming to us for leg pain of one sort or another. Now that might be a pain that happens with venous insufficiency, but we find that they have arterial insufficiency. So it's a whole those people get kind of shunted into a whole different treatment.
Yeah,
pattern.
I was going to ask you that because I'm just guessing. Although I've never asked this question, and folks, I ask a lot of questions, and I kind of remember most of what Dr. Juleff says. Because the arterial system seems to be less complicated. Is it possible that somebody has absolutely nothing wrong with their arteries, but lots of stuff wrong with their veins?
Oh, yeah.
And vice versa. Yeah. To me, that's interesting.
Yeah. And then there's a small number of people who have both, unfortunately.
Yeah.
But it actually, it has always been surprising to me that, most people either have arterial problems or venous problems. There aren't a lot that have both.
Yeah.
Again, it's always been amazing to me that there aren't more with both.
I'm just guessing that most of us, and when I say that, as I used to be that, really don't understand the real difference between it. They just think the whole circulatory system is just one system. Mm-hmm. But the difference is, from what you've told me, is the veins have a lot tougher job. Because at the top of where the arteries work, there's this big, huge thing called the heart, and it's a big old pump.
Yeah.
And as long as that's pumping well, you got a good heart, you got good arteries, full of blood.
Yeah. Blood through veins does not move because the heart is pumping.
Yeah. So you got to get it back uphill some way.
Yeah. The veins are an amazing thing. They make it happen. But some of the other things that we might do is a CT scan.
Okay.
CT scan, specifically looking at veins, and that we do that usually if we feel like there's a problem up higher than just in the legs, because sometimes there is. Sometimes there's a problem with the larger veins that are within the pelvis, or even
is that harder for an ultrasound to discover?
Yeah, very much,
okay.
very much so. So, and that's why we have to rely on either CT venogram or sometimes we do an MR, what's called an MR venogram. It's sort of like an MRI,
and like an MRI, but about the circulation. Right?
Yeah. And then very occasionally, not so much anymore, but this is one of the things that was done, a lot more commonly in the past is, standard venogram, where we, inject contrast into a vein and then watch it go up or down or whatever.
We've talked about in the past, and particularly here in Hawaii, the number of people that are large, the people that are obese. And of course, the question always comes up, is it more difficult to diagnose and treat somebody who's twice as big as they should be, or not necessarily they should be, but they're twice as big as somebody that might be easier to treat or easier to diagnose?
Yeah, in a sense, especially as it relates to venous disease. Yeah, obesity not only causes progression of venous insufficiency. But from that standpoint, is it harder for us to treat it? Well, no, not really. But it's often multifactorial. For instance, swelling. Yeah. We see a lot of swelling in the obese population. dilation, and invariably that's due to not only venous insufficiency but also this thing we call lymphedema. So it's a little more, they are a little more difficult to treat.
You know, when you hear somebody talks in a family, and this happened just recently with a friend that says, you know, I'm the oldest of my family. Nobody in my family's ever lived as long as I've lived. And I'm not saying that I've got a good life, but what are some of the reasons to do that? And you said that sometimes, unfortunately, venous insufficiency is something that we're getting. It's hereditary, that we're likely not to be able to fix it. No pills, no diet changes, but yet what do? Okay, mom had it, I've got it. I don't want to go through what mom did. What are you going to do for me?
Right. Sure. Yeah. We a lot of that that kind of is a deterrent to people coming in and getting fixed.
Mm-hmm.
You know, they feel like the therapy is going to be worse than the disease itself, so they don't even attempt.
Well, you know, particularly in a lot of local families that have where the life expectancy used to be late 50s, early 60s, and now they're living into their 70s and sometimes 80s. When somebody gets into their 60s or 70s, they're almost resigned to the fact that that's when people in my family die.
Mm-hmm. Sure.
And maybe adding a couple of years more quality life is worth going through the treatment or the diagnosis that they need for this, because of the fact, like you've said, that this is a disease that really, really takes a long time for most of us to develop.
Right. So after we do, all the diagnostic things that we feel would be appropriate for that patient, then that's at the point that we then, sit down with the patient. We've got all the information. We can say, hey, this is what we see specifically in you, and then we try to outline what we feel can be done for them, and discuss the progression of the treatment, discuss again, what they can expect to benefit from after treatment. And, so we go through all that with them at that point.
Well, here's the thing, and I think this is important, because of your professionalism in the clinics and the diagnostics, you're able to determine at what point somebody is on the scale. Mm-hmm. So not everybody gets rushed to the ER for an immediate operation on their legs. As a matter of fact, it would seem to me that you can come up with a more conservative plan that's lasting over a longer period of time. I don't know if those are the right words, but you get what I mean is that
sure.
You say to a patient, look, yeah, Mike, you do have some issues. The good news is that we can get at them. We can get at them in an orderly process. You don't need to say, not enjoy Christmas this year with the family. You're not going to have to worry about that.
Yeah.
Or something.
That's all very correct. Even before we start to, as soon as the patient, comes into the office, if we have a very, very high suspicion that they have vein problems, we initiate what we refer to as conservative therapy.
Yeah, okay.
And so we get that going right away. Now, what is conservative therapy? Well, conservative therapy is the use of compression stockings. That's one of the things that we do. Mm-hmm. We also use elevation, although elevation does not seem like a huge deal. It can be very important.
I got to tell you, I love the elevation, but I did learn from you. You can be elevated for 3 hours and feel pretty good. You stand up in 5 minutes. What used to be gone from the elevation is right back.
Yeah,
So,
exactly.
However, that's not the point, is it? The point is that if somebody feels better, and if they can get a better night's sleep because they elevate, that's going to give them more reason to want to not accept immobility.
Mm-hmm. Right. So elevation, helps, and you have to sort of schedule it into your day. Sometimes I ask people if they're having a lot of swelling. I ask them to, a couple times throughout the course of the day, lay down on the couch, get your legs up on a couple pillows, and that really does, have a beneficial effect. Now, you have to sort of use that in conjunction with compression stockings. Like you said,
sure.
You can elevate your legs, you get rid of all that swelling. Often that happens overnight. A lot of people will say,
even if your legs aren't all that elevated,
right.
you're prone.
Yes.
So it's a little easier for that. Right?
You're flat and the fluid is moving in the right direction. But, what I tell people is that, if you're having a problem with swelling, then, and if the swelling does recede a fair bit, overnight, then the absolute first thing that you have to do when you get up in the morning is put on your compression stockings.
Yeah. Now, is this feeling specifically trackable to a venous insufficiency? I mean, obviously, any relief from elevation is a good thing. But if it right away happens, is that probably a venous deal rather than just something else?
In my experience, I would say that is true.
Mm-hmm.
Yeah. Those people who have much more complete resolution of swelling that occurs overnight, those people who respond very quickly to elevation during the day, those people are more likely to have kind of a single cause, and often that single cause is venous insufficiency.
Yeah. Okay, so anyway, it gives somebody a whole bunch of options, and I know that some of it, some people have to plan for finances, so that's in the cosmetic end of it. But I guess what would be the when you fill out my forms to submit an insurance claim for the work that you're going to do for me, what sort of questions do the insurance companies want to know about either the aggressiveness of the treatment or the conservativeness of the treatment?
Well, that's a good point, because the insurance companies these days, they do mandate that we treat most people conservatively, and by that I mean I don't mean less. Conservative doesn't in that case imply we're treating them any less than what we could otherwise do, but we're just using, conservative therapy is sort of implying that it is not interventional therapy.
Gotcha. Yeah.
So the insurance.
Okay, good.
The insurance company actually wants us to treat people for anywhere from 60 to 90 days conservatively, before they will, authorize us to go ahead with the procedural things that we do. Now, why do they do that? Well, the reason they do that, basically, is that they want us to prove to them that conservative therapy isn't going to be enough for that patient.
Really a good point. In other words, here's the deal. When you talk about compression stockings, which we've done, that's going to probably come along early in the piece, because isn't it, in fact, sometimes that this insurance company knows we're going to want to say, okay, Dr. Juleff, what have you already done to this person, and what have been the results of that? Show us.
Right, exactly. That's exactly what they are asking us. And then, the insurance companies want to know, some of the more medically specific kind of things, too. We rate or we grade venous reflux. By reflux, I just mean the blood's going in the wrong direction. But we use timing to sort of grade how bad the reflux might be in any one person as opposed to another.
Hey, wait, this is really important, because I know that some of these things you have to observe when a patient is in your office. And you lay somebody down, you elevate them, you got to do this thing. But in actual fact, there's nobody doing that for them the rest of their day. Yeah. When their legs start hurting at night, maybe that didn't show up in the examination you had at 3:00 that afternoon.
Yeah. Well, actually, with respect to the rating of the venous reflux, we do that with ultrasound. That's something that we do with ultrasound. So we can actually, and it's pretty accurate. It's very specific. And, we're watching with the ultrasound, we're actually watching blood go in the wrong direction, and we're timing it. And so the insurance company wants to know that time.
By the way, Dr. Juleff has some great people doing that, and I'm just guessing. And you can check this out for yourself. Look at the staff and look at the happiness at these places, the clinics, Kauai, Maui, the Big Island, and of course here in Honolulu, at VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com. It looks to me like somebody that wants to get into the field, not as a physician, but just as a worker or a nurse, that there are so many opportunities, particularly, and it seems to me that you even see ultrasound equipment now on the sidelines of a football game. I mean, it is really getting to a point where this is a major tool.
Absolutely. Ultrasound is just used in so many settings anymore. It's amazing. But it's been a tremendous technology that was, developed, again, not all that long ago.
Let me tell you, as a patient, the way it makes me feel, and that is I can see it. And, there used to be a time when you had an X-ray and they'd put it up and they'd say, this is it. Well, wait a minute. you can actually see this thing. When they say push, you push, boom, you boom, this stuff squirt, and it's making a sound. It really gets you involved and say, wow, that's all me. That's all me in there.
Yeah, patients do love to watch.
Yeah, I do. I'm fascinated by it.
It's because, and we do. The ultrasound techs are good at that. They're kind of explaining to the patient while they're doing the study, so that they can see what's going on, and they can visualize what the problem is. And I think that's a huge part of it.
Amen. And I don't know if this is a riddle or not. They say, if a tree falls down in a forest and there's nobody there, does it make a sound? I'm just imagining, now that I've had this experience, there are a lot of gurglings and things going on in your body, aren't there? That you guys can actually hear it. You can actually hear blood flowing.
Yeah.
Yeah, it's really amazing.
Yeah.
Okay, so
we have to go through this conservative therapy, for the good of the patient to conform to insurance requirements. But there are a couple of instances where we don't have to, and I think we were talking about the urgency.
I was going to say these are the urgent ones, right?
Yeah. And like we mentioned before, if somebody comes in with an ulcer, that's an urgent sort of problem. We treat it. We try to get that ulcer, kind of healing, moving in the right direction. Try to get rid of some of that swelling, and we do that with wraps and dressings, etc. And then we can move on whenever we feel like that patient is medically fit to move on with procedures. Then we can. The other thing that is considered an urgency is spontaneous bleeding.
Right. Whoa. That sounds scary.
And, and it doesn't happen very often, but sometimes it does.
We talked about this a couple of weeks ago.
Oh, yeah.
And that was every now and again somebody's taking a nice hot shower, and all of a sudden they're squirting blood on the wall and they flip out.
Right. Yeah, because it looks
can't say you blame them, can you?
No. It looks like, especially in the shower, it looks like a tremendous amount of blood. Now, some people can lose a fair amount of blood from those, spontaneous bleeds. And that's why it's an urgent problem that they allow us to go ahead and treat right away. But the important thing to remember there is that it's not difficult to stop the bleeding.
Yeah, don't run and run down to the ER.
No.
What you want to do is stop where you are, stick them up in the air.
Yeah. Put your legs up, on the wall, and then have your wife, hold where it's bleeding, and it will stop. Yeah. It will definitely stop.
And these are some of the things. I do know that some of these experiences, people freak out, and they think, oh, my goodness, is this it? Am I going to bleed out here? But I want you to feel confident. First of all, like I said, go to veinclinicsofhawaii.com and see the breadth and scope of what Dr. Juleff and his team do. Because I think that at the end of the day, pretty much what you're doing now is a well-beaten path. With the diagnostics that you have now and the case studies and the success ratios, pretty much everybody's going to fit somewhere on that scale that you have of 0 to 6 and get identified and treated. This has got to be the biggest bonus and the biggest thrill of your staff and yourself.
Yeah, it really is, especially given the fact that, number one, venous disease is tremendously common. By the time that people are in their 50s and 60s, 50% of the American population, adults in that age range,
listen out there, you all now,
is going to have some amount of amount of significant venous insufficiency, and that causes symptoms, and we can treat those symptoms in a way that was done, that's done now much better than it was before, with reliable relief of symptoms. And when people, after we treat them and they say, gee, my legs feel great, that gives us tremendous amount of pleasure.
Listen, if it gives you the ability to walk around the block or walk to the mall or go on a hike or take a trip or go see the grandkids or just plain get along, play tennis again, who knows, go out and paddle a canoe, all the stress and strain's kind of worth it, isn't it? Mm-hmm. Okay, folks, what we want you to do is go to veinclinicsofhawaii.com and see this for yourself. Any questions that you may have, you can email. You can also call for an appointment. You can get yourself set up. And I'm telling you, getting a consultation and getting involved in this system would be one of the smartest things we can recommend. That's why we do the program. That's why we let you know that the Vein Clinics of Hawaii is on 4 islands, on the Big Island, on Kauai, on Maui, and here on Oahu. And all you've got to do, it's simple. Go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com, and get those legs straightened out and get yourself in better shape. We'll see you next time. Tell everybody about it. Once again, veinclinicsofhawaii.com.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com.